Have you seen the headlines after the Cochrane review came out? Where it read, anti-amyloid Alzheimer's drugs show no clinically meaningful effect. In other words, the drugs so many folks have been pinning their hopes on, the first disease-modifying drugs, don't seem to be making a real difference for people living with Alzheimer's. And if you caught last week's episode on ApoE4 and GLP-1s, and the one way back in November, the one about the brain eats itself with two health influencers, you already know I've been building to this episode. Because both of these stories, and so many more, reveal the same underlying problem. That most people don't know how to interpret the evidence. And that's costing us dearly, right? Either in unnecessary fear or in false hope. So today, I'm going to attempt to fix that. We're going to look at the hierarchy of evidence, what it is, and more importantly, how to apply it so you're not fooled or misled by the headlines or health influencers. All right? So let's get started. Welcome to Happy and Healthy with Amy, the brain health podcast for women in midlife who want to not just survive, but actually thrive during the menopause transition and beyond. Well, hi there, Amy here. Thank you so much for joining me today, and welcome back to another episode of Happy and Healthy with Amy. So if you've been following along, last week we talked about ApoE4 and GLP-1s. And this episode is the natural next step. So if you haven't listened to that one, okay, the link is in the show notes. And I would also recommend you go back to my episode from November of 2025 on The Brain Eats Itself During Menopause, which was a video that scared a lot of women. Okay, these are going to give you a lot of useful context for what we're doing today. Again, I've included the links for both of the episodes in the show notes. Because today, we're going to be talking about the recent Cochrane review. So recent as in it was just published on April 15th of 2026 on the anti-amyloid drugs for Alzheimer's. And to understand why it matters, and why it doesn't mean what some headlines are saying it means, you need one essential tool for critical thinking. It's called the hierarchy of evidence. And I'm going to walk you through it fairly quickly, and then we're going to apply it. Okay? So the hierarchy of evidence, I want you to picture a pyramid. Okay? At the base, we've got anecdotes, testimonials, animal studies, and expert opinion. So we're talking about the base, right? There's lots of these, and they're very easy to come by. So an anecdote is someone's personal experience. Like, I started taking this supplement and my brain fog disappeared. And maybe it did, but we have no idea if the supplement caused it, if it was the placebo effect, if this person would have started sleeping better that month regardless, or if it would work for anyone else, right? One person's story isn't evidence-based medicine. It's a starting point for a question, for a hypothesis. Now, a testimonial would be someone's observation, a subjective observation. Right? And an expert opinion is still just that, an opinion. Albeit from someone who probably knows more than most. Okay? Then we've also got animal studies using mice or rats or other animals. Usually because you can control their environment in ways you can't control with people. And because you can usually move faster too. So if you listen to my episode back in November on The Brain Eats Itself During Menopause, right, that hook, You heard a perfect example of this. So Dr. Roberta Brinton's research on brain metabolism and menopause was done in female rodents. Okay, genuinely important mechanistic work, but it's at the base of the pyramid. And two health influencers, really well-meaning women, okay, took what happened in rats and said, this is what happens in women. But that's extrapolating, right? It's a big leap. So again, these are all interesting starting points, right? Important for generating ideas and questions, but they can't tell us what actually works in human beings. So in the middle of the pyramid, we have observational studies. So less of these than the base. Okay, so these involve large numbers of real people looking at real patterns. And it's useful, but these studies can only show associations. They can't prove that one thing caused another. Okay, so let me give you a real example of how badly this can go wrong, because it's one of the most famous cases in health research. So for decades, observational studies kept finding the same thing. Moderate drinkers had lower rates of heart disease than non-drinkers. Study after study. It looked rock solid, right? And it gave rise to the idea that a glass of wine a day was actually good for your heart. But when researchers dug into the UK Biobank, this is one of the world's largest health databases. We're talking hundreds of thousands of participants. They found something important. Yes, moderate drinkers had better heart health, but they also tended to exercise more, eat more vegetables, and smoke less. So they were basically healthier people overall. So the alcohol wasn't the reason, it was just along for the ride. And there was another hidden confounder. It's called the sick quitter bias. So a lot of the non-drinkers in these studies weren't lifelong abstainers. They were actually former drinkers who had quit because their health had already deteriorated. So the comparison group was sicker, which made the moderate drinkers look healthier by comparison. So this is classic confounding. Okay? When the researchers used further analysis to strip out these confounders, the apparent protective effect of alcohol essentially disappeared. So same data, more sophisticated analysis, very different conclusion. Okay, so back to the pyramid. Above observational studies, we have randomized control trials, or RCTs. Okay, this is where researchers actually test something. Randomly assign people to groups, right? A control group and an intervention group. And then they measure what happens. So the gold standard would be a randomized, double-blind, which means neither the participant nor the researcher knows who got the real treatment. Okay, controlled, meaning one group gets the intervention and the other gets a placebo, the control, right? And here you're looking for causation, not correlation. So the more participants and the longer the study, the better. Usually the better. So this kind of design eliminates a huge amount of bias. And then at the very top of the pyramid, we've got systematic reviews and meta-analyses. So these look across many randomized control trials and ask, when we pull everything together, what does the evidence consistently show? And that's where the Cochrane reviews live. Okay, that's why they carry so much weight. So the higher we get on the pyramid, the less we're asking, does this make sense biologically? Right? Again, where we're looking at mechanisms of action. And the more we're asking, does this actually help real people? Okay. Now here's how all of these show up in the vocabulary. Because when someone is talking about research, okay, and they use these words correctly, that's a signal. It tells you they understand the nuance. And when they skip them, it's also a signal, or more accurately, a red flag. So we're going to go through 9 terms in plain English. And I promise you, you're going to experience the payoff in about 5 minutes, maybe 10. Okay? The first 2 terms, correlation versus causation. So correlation means 2 things tend to happen together. Causation means one thing actually causes the other, right? They're not the same thing. So when you think of Chanticleer the rooster from the Canterbury Tales, every single morning Chanticleer crows and the sun rises. Every time, without fail. So Chanticleer concluded, my crowing causes the sunrise. He has a perfect correlation. He has 0 causation, right? The sun was going to rise anyway. He just happened to be there making noise. So here's the signal. A careful communicator never uses linked to and causes as if they mean the same thing. So if they do, pay heed. Next term, confounding variable. I've used this term already, right? Chanticleer's mistake was missing the confounding variable. In his case, we're talking about the rotation of the Earth, right? So, a confounder is a hidden third factor that actually explains why 2 things appear related, like the sick quitter bias, right? Another real example from the last episode was the observational studies that showed GLP-1 users have lower dementia rates. But most of those users were being treated for type 2 diabetes, which is itself one of the biggest risk factors for Alzheimer's. So, did the GLP-1s protect the brain directly? Or did better blood sugar control reduce their Alzheimer's risk? And the drug just got credit, right? This is exactly why we need randomized control trials. So again, here's what I want you to pay attention to. If someone doesn't name what else might explain their finding, ask them. Okay? Next 2 terms, mechanistic versus clinical evidence. So mechanistic evidence explains how something works in a cell, an animal, or in a lab, even in people. Okay? Clinical evidence tests what actually happens in people, in real people. So something can have beautiful mechanistic logic and still fail clinically. So the amyloid cascade hypothesis is, I think, one of the clearest examples of this. Okay, so here's a really important signal to pay attention to. Okay, when someone says the research shows this works, make sure you ask, in mice or in people, right? And is that outcome of how it works meaningful? So 2 more terms, statistical significance and clinical significance. So statistical significance means the result probably isn't due to chance. Okay, so usually there's a p-value of less than 0.05. Clinical significance means the effect is big enough to actually matter in someone's life, right? We're talking about health outcomes here. So a drug can be statistically significant and clinically trivial. In other words, producing a change so small that patients don't ever really notice it. So if someone only tells you a result is significant, okay, ask significant how? Like by how much in real terms? Okay, then the last two terms, absolute risk versus relative risk. So relative risk is a percent change, as in reduces risk by 50%. Absolute risk is the actual numbers. So from 2% down to 1%. Okay, headlines tend to use relative risk because they sound bigger, right? A 50% relative reduction from a 2% baseline is only a 1% point change. Very different story, right? 50% versus 1%. So this is one of the things that happened with the World Health Initiative. The headline talked about a 25% increase in the relative risk of breast cancer. But the actual number, it only went from 4 to 5 out of 1,000 women, right? So this is what I want you to pay attention to. If they only give you the relative number and never mention the baseline, right, that's worth noticing. It's worth asking about. So the mark of someone who really understands the evidence isn't certainty. It's calibrated honesty about what it does show and what it doesn't show, right? They're really careful about the language they use. And they rarely use absolutes or make bold, definitive statements. So instead, they're very circumspect. Okay, so now let's dig into the Cochrane review. So to give you a little background, for decades now, Alzheimer's research has been dominated by the amyloid cascade hypothesis. So the idea, in very basic terms, is this. Amyloid plaques build up in the brain, okay, trigger a cascade of damage. So we're talking about phosphorylated tau and neuroinflammation, which then eventually destroys memory, right, and other forms of cognition. Therefore, the solution, right, to remove the amyloid plaques seems logical. Now, amyloid has strong lower pyramid support, right? It exists in Alzheimer's brains. It's measurable. The rare genetic form of Alzheimer's, right, early onset Alzheimer's, clearly involves amyloid processing. That's solid mechanistic evidence. Biologically plausible. A very reasonable hypothesis. But a hypothesis needs to be tested all the way through to the top of the pyramid. And that's exactly what's been happening. Billions of dollars, decades of drug trials, all aimed at the same target in RCTs. And when you put all of that evidence together and ask the pyramid's most important question, does removing amyloid actually help real people? That's where things got complicated. So the Cochrane review, right, this was a systematic review and a meta-analysis, the highest level of evidence we have for evaluating whether a treatment works or not. It looked at RCTs on amyloid beta targeting monoclonal antibodies for people with mild cognitive impairment or mild dementia due to Alzheimer's disease. So researchers analyzed 17 randomized control trials, which included over 20,000 participants. Okay, so these folks had either mild cognitive impairment, MCI, or mild dementia due to Alzheimer's. And the drugs included lecanemab, donanemab, aducanumab, and several others. Okay, and here's the key thing. The central question was not, can these drugs remove amyloid? Okay, we already knew the answer. Yes, they can. The question was, does removing amyloid translate into meaningful improvement for people, right? Clearer thinking, better functioning, more independence, right? So here's what the review found. On cognitive function, little to no meaningful difference compared to placebo. So the effect was statistically detectable, but clinically tiny, right? Too small to notice in daily life. On dementia severity, little to no meaningful difference, even below the threshold for clinical significance. And then on daily functioning, small at best. So a possible small signal was in complex tasks like managing finances or taking medications, but really limited overall. Okay, and then when it came to safety, one of the side effects is called ARIA, A-R-I-A, which is basically amyloid-related brain swelling and bleeding. Okay, and this increased substantially. We're talking from 12 cases per 1,000 people on placebo to about 119 cases per 1,000 people on the drugs. Now, many of these cases were caught on MRI scans without symptoms. Okay, but some were symptomatic, as in people experienced headaches, confusion, dizziness, and in some cases more serious neurological effects. So in plain English, these drugs can remove amyloid, right? And they did a good job. But removing amyloid isn't the same as preserving memory and cognitive function. It's not the same as preserving independence or quality of life. And when the potential benefit is small, right, and the risks are significant, the decision about whether or not to get the treatment gets harder, right? Gets much, much harder. Now, this is where your new vocabulary pays off. Okay? Remember, statistical significance versus clinical significance. This is a real example. So, the drugs did produce a statistically detectable effect, right? But the effect was clinically trivial. So the difference was real, right? Not chance, but the impact wasn't meaningful. And that gap between what the study can detect and what a patient actually experiences is exactly what the top of the pyramid is designed to reveal. Okay? And notice the absolute versus relative risk framing. So the ARIA numbers, we said 12 per 1,000 versus 119 per 1,000. So that's a relative increase of roughly 10 times, which sounds enormous, right? But in absolute terms, we're talking about a difference of about 10% of patients. Now, that context doesn't make the risk disappear, right? But it does provide important context to help you think about it. Now, the Cochrane review has been criticized, and I believe some of that criticism is legitimate and worth taking into account. So the Alzheimer's Society and several researchers argued that pooling older, failed anti-amyloid drugs with the newer ones, like lecanemab, which is marketed as Leqembi, right, and donanemab, which is marketed as Kisunla, may blur some important differences, right? The newer drugs are more targeted. They work better on amyloid removal. And it may not be fair to average them together with drugs that were abandoned like a decade ago. Okay, I think that's a really valid point. So the Cochrane author's argument is that all of these drugs share the same core mechanism, that they all target amyloid beta. So then a class level question is reasonable. So This is, again, probably why the amyloid cascade hypothesis is still a hypothesis and not a theory. But I still do think it's fair to stay curious about whether the newer drugs perform differently in a dedicated analysis. But the takeaway isn't amyloid research is dead, okay? Everybody go home. That would be way overstating. I think the better takeaway is amyloid matters, but amyloid removal hasn't delivered clinical benefit proportional to the hope that's been placed on it. At least not for people who already have early symptoms. And here's another thing worth noting. Researchers working on anti-amyloid drugs are also asking a different question. What if we're treating too late? Okay, so that's what the AHEAD trial is testing. It's a phase 3 trial of lecanemab in people who are completely cognitively normal, but who already have elevated amyloid building up in their brains. So they're preclinical, as in no symptoms, okay? And the idea here is to see if amyloid removal might work better before the cascade of damage has already started, right? So think blowing out the match or removing tinder so you prevent the brush fire that eventually can become an out-of-control wildfire. So the enrollment for the AHEAD trial closed in October of 2024, and the results are pending. Okay, but this is a question being asked right now. Now, before those results even come in, here's what the AHEAD trial tells us. Okay, the research world itself is now acknowledging that Alzheimer's doesn't start at diagnosis. It starts decades earlier, which means the conversation about prevention, right, the one we've been having on this podcast for a while now, that conversation is worth having. And that brings me to what I think is the most important and most hopeful piece of all of this. Because, and if you listened to last week's episode, you already know this part. The most compelling clinical evidence for Alzheimer's prevention right now is not a drug. It's lifestyle. The finger study, the US pointer study, the Ornish-Tansey lifestyle trial, right? The Lancet Commission's report on the 14 modifiable risk factors for dementia. All of them point to lifestyle. Okay, we're talking sleep, movement, nutrition, stress management, social connection, hydration, challenging your brain. Okay, these are either randomized control trials or, in the case of the Lancet Commission report, a systematic review that uses meta-analysis as part of its comprehensive assessment. So all the things that we're talking about here have either been tested at or near the top of the evidence pyramid. So lifestyle is not what you do because there's no drug. Okay? It's what you do because your brain is adaptive and responsive and resilient. And midlife, especially for women going through the menopause transition, is exactly when your brain can really benefit from more support. So let's stay curious about the MABs, the lecanemabs, donanemab, and whatever comes next in Alzheimer's research. Okay? We're not going to throw out amyloid science just because the story is messier than we hoped. Okay? But let's also recognize that amyloid may matter, that tau and neuroinflammation may matter more once symptoms appear, and that when it comes to prevention, lifestyle definitely matters. Okay, so if today's episode has stirred up some fear, okay, especially if Alzheimer's runs in your family, I don't want you doom scrolling, okay? I want you taking one clear next step. Okay, and that is to download my free Restored Protocol Guide at moxie-club.com/restored. So it walks you through the 8 essential evidence-based lifestyle factors that will help you optimize your brain health in midlife and beyond. These are all things that have been tested. These are things that work. And as always, the link is in the show notes. And if you're on YouTube, the QR code is on the screen right now. All right? And to be clear, my goal is not to instill fear. My goal is for you to take the data, right, and be able to interpret it in a way that's empowering so you can take action consistently, with compassion, and one easy step at a time. All right? So I want to wrap things up today with a quote by Marcel Proust. The real voyage of discovery consists not in seeking new landscapes, but in having new eyes. Hi there. Would you please do me a quick favor? If you're a woman in midlife who wants to protect her brain, especially if you have a family history of Alzheimer's, please subscribe, right? This channel is for you. And I post every week. So not only do I not want you to miss my next episode, as the channel grows, I'll be able to access harder to book guests who have really valuable insights and wisdom that I think are best learned directly from the source. Right? And if this episode resonated with you, please be sure to like and share and watch this episode next.